Hey everyone, welcome back to Urgent Care Stories. Today's episode is a complaint that when it first came in it sounds like something else, and then turns out it's actually a completely different reason for that complaint. This patient was a African-American woman in her 60s. She had a history of high blood pressure, cholesterol, diabetes, your pretty typical stuff for somebody that age range. A little overweight. She comes in and she's complaining of left shoulder pain. She, when you're getting your history, you hear that basically she has a known bursitis and a chronic rotator cuff tear to the left shoulder. She's been seeing her primary about it. She has a referral to an orthopedic doctor. She's had an injection for it, and she's undergoing physical therapy. So that's the history with the shoulder. You ask her, so tell me what's going on right now. Has it worsened? Has anything changed? Have you had a fall or trauma or anything like that? She says, well, no, I haven't had any injuries, nothing like that, but the pain has seemed to get worse in the last 3 or 4 days. So thinking broadly, shoulder pain, that can be anything from a neck issue, a shoulder issue, it can be chest pain, it can be belly pain sometimes, it can be shingles, it can be cellulitis or skin infections, it can be a number of different stuff. So the questions that you need to ask help you kind of determine where your source is. So somebody in this age range, my thought is obviously shoulder being the issue is number one, but could it be neck? Could it be cardiac? Could it be belly? That sort of stuff is all what I'm thinking. So my questioning is, hey, do you have any neck pain? Do you have any pain that radiates, down the arm, numbness, tingling, anything like that? She says, no, it's pretty much localized to the left shoulder. I say, does it hurt when you move it? Yes, it seems to hurt when she moves it. Is she having any belly pain? Is she having chest pain? Is she having shortness of breath? She says no to all that stuff. So at this point, we do our exam. Looking at it, we want to look at the skin first. Her skin looks healthy, no rashes, no cellulitis, everything looks clear there. I feel her neck, I push down the center of the spine to feel the bony prominences, no tenderness. I feel the paraspinal muscles and the upper trapezius muscles. She has a little bit of spasm in the trapezius, but it's not tender to touch. I then go into the shoulder itself. So I passively move her shoulder. She has full range of motion of the shoulder. Everything moves pretty pain-free with me moving it. So that tells us that the structures are at least working properly. It's not dislocated. I don't feel a lot of crepitus or signs of arthritis or something like that. Then I have her move it actively, and she actually does pretty well. It's not too sore for her to move the shoulder around. Next thing I do is I start pushing on it. So I push on the bicipital groove, where the long head of the biceps, that tendon comes around the shoulder into the glenoid. I feel the greater and lesser tuberosities of the shoulder for the rotator cuff insertions. I push on the supraspinatus tendon and kind of where that muscle wraps. I push on the back of the shoulder, some of the bursal areas of the shoulder. Nothing is really getting her to jump off the table. Nothing that's causing her to have pain. So at this point, I'm thinking this is a little odd. She's had known history of shoulder issues confirmed by MRI. She's been getting treatment for it, but now the pain has actually worsened in the last 4 days, but I can't reproduce any of her pain. This is one of those signs or one of these kind of examples where you have somebody who their physical exam and their history, they're not matching up for you, and that should let some bells go off in your head and say, hey, something's not right here. This doesn't make sense. So I say, are you sure you're not having any chest pain? She's like, nope, I'm good. Shortness of breath? No. I say, okay, well, hey, I'd like to do some x-rays of the neck and the shoulder and the chest, and I'd like to do a little bit of a cardiac workup just for my peace of mind, just to make sure that we're not missing something. She says, okay, that's fine. So my cardiac workup, I basically start with an EKG. I do a chest x-ray, and I do some x-rays of the shoulder and everything. Neck and shoulder x-rays show pretty stable bone findings, no significant arthritis. It's not an obvious, like, oh, there's an impinged nerve type of a finding on the cervical spine, and the shoulder also looks pretty healthy on the x-ray. The chest looks clear. I don't see any pneumothorax, tension pneumos, heart's normal size, no fluid backup, everything there looks clear. So we get her EKG. Her EKG has no changes to the ST segment. There's no depressions, there's no elevations, but the T waves in some of the, I think it was V3, V4, some of the T waves are inverted. Now the ST segment is isoelectric, it's stable, it's normal where it should be, but those T wave inversions, I didn't like that in the presence of shoulder pain with no other explanation. So I said, hey, look, I'd like to get a little bit of cardiac enzymes on you. My thought process was I just need to run one set of enzymes. She's been having this pain for 4 days. A troponin will take about 2 hours to elevate and will stay elevated for about a week after any sort of damage or issue to the heart. So if I get one troponin about, a couple days in from what she's been dealing with, it'll tell me if it's negative. It gives me the peace of mind knowing this is nothing cardiac. We do her cardiac enzymes, and sure enough, she's got a mildly elevated troponin. I think our cutoff is 0.06 is our normal, and she was at 0.09. So again, slightly elevated, not significant, but in the presence of this woman's symptoms and EKG findings, this is an NSTEMI, a non-ST elevation myocardial infarction. So it's a heart attack, but it's a heart attack that has not destroyed or killed the muscle yet. It's just damaged or injured the muscle. So at this point we say, hey, look, your EKG looks a little funky, but not terrible. Everything with the shoulder is normal. I think this is your heart. I think you're having a little bit of a heart attack here. And I think you need to get into the hospital. I think you need to be admitted, have some stress testing and further cardiac evaluation, decide if they need to take you to cath lab or not. Once I mention all this stuff to her, finally she admits, you know what? I have been having some pain that kind of comes into the left side of my chest. I said, well, there you go. So remember, your patients are not always going to be 100% honest with you. Sometimes they're just going to tell you the bare minimum because they just want to get in and out and get some pain meds for their shoulder pain. But this was one of those instances where this was an atypical chest pain presentation. And this was in a patient who you would expect to have an atypical presentation. She's female. Sometimes women have different presentations of their chest pain or their MIs. She's diabetic. Sometimes diabetics have weird presentations. So when somebody comes in with an issue like this, you can see how the history and the physical exam didn't match. That was my first clue. Then thinking broadly, I thought, well, I can't definitively rule out a cardiac issue based on her history and physical alone, so I need to do some workup. When that some workup didn't give me the confidence that I could rule it out, I went on further and we eventually got to the right diagnosis. She ended up getting admitted to the hospital for a few days. I never followed up with this patient, so I don't know what all happened for her, but at least we got her to where she needed to be. Obviously, she was looking pretty stable when we saw her. There wasn't really anything going on. She wasn't short of breath. She wasn't tachycardic. She wasn't diaphoretic or sweaty. She looked fine, and the pain didn't seem that severe. So I think this was something that could definitely be kind of managed with cardiology and let them kind of take the reins from here. But it's one of those atypical presentations, and you always got to remember that these can come into the primary clinic. These can come into the urgent care. These can come into places that are not always the emergency department, and you just have to be able to recognize the signs and symptoms of something like this, guys. Hopefully you find some benefit in learning a case like this. It was one of those atypical presentations, and I will see you guys in the next episode.